Here with the last lecture on radiography of the large intestine, I'm going to talk about a few more diseases of the large intestine, then kind of wrap it up. Looking at the margin of the large intestine, if you think about the serosal edge, basically the visibility of that edge relates to the peritoneum surrounding the colon, just like with every other organ. So we usually see the serosal margin because there's mesenteric fat around it. That margin may be wavy, it may be smooth, it may be spastic. When it is spastic, that can indicate colitis if there's a sort of hypersegmentation of the colon, but sometimes we see that normally. When there is normal movement, normal haustrations and mixing movements, you can see transient hypersegmentation or apparent spasticity or corrugation of the colon. So this is a normal animal. These are survey radiographs on a dog, and here in that descending colon, we see this spastic or hypermodal or corrugated appearance of the colon, a very wavy, irregular sort of serosal edge and even mucosal edge. And that looks, abnormal. It could be colitis, but then other radiograph, this is just seconds later, completely smooth, no evidence of that spasticity or hypersegmentation whatsoever. So that was just normal transient colonic activity and does not represent colitis. Occasionally we do see foreign objects in the colon. Usually they're not of any clinical consequence because they had to get all the way through the stomach, through the pylorus, through the small intestine just to get to the colon, and the colon has a little bit more room to work with. So most of the time foreign objects that get to the colon will end up passing uneventfully. Every now and then, though, one will get stuck, so you can't 100% assume that all will be okay. And perhaps more importantly, you have to confirm that that object really is in the colon and it doesn't represent some small intestinal foreign object that then might be of greater significance. Of course, there are some things that are iatrogenic when you're radiographing patients, so rectal thermometer is a normal thing that's okay to be there, at least temporarily. Here we have a case in a dog, and I'm jumping straight forward to the pneumocolonogram, where we have a mineral object that is in the abdomen, and it is in some sort of intestinal segment. Fortunately, we've done the pneumocolonogram at this point, and we can see that that gas continues back toward the rectum, and as we go to other views, we'll be able to see that it is pretty definitively within the colon. Again, since it got all the way there from the small intestine, the odds of this causing a problem are pretty low. Another dog, starting with survey radiographs. Here we have some heterogeneous material. And some of this material is pretty compellingly in the descending colon. It looks like it's continuous with the gas that moves on back toward the rectum. So this is probably fecal material, but there's this other streaky, striated, soft tissue and gas opacity material a little further forward in the abdomen, which might be within the large intestine, but then again, it might not be. And so that's something we might want to figure out. So again, on survey radiographs, I can see that this material more caudally looks pretty suspicious for just normal fecal material, but this streaky striated stuff, again, might still be in the colon, but I don't think it's a slam dunk at this point. So here we need to consider doing a pneumocolonogram. Dilate the colon with gas, see if the gas will get all the way around that material to demonstrate that it is in the colon, or once we've identified the colon, confirm that this material is in some other loop. Here we've administered the gas, and we can see that the gas is kind of moving itself around all of the streaky material that was further forward as well, on up into the rest of the colon. So now we can be much more confident that this is fecal material and cloth material or some other foreign material in the colon. And again, it's not in the small intestine, which is the main question here. Again, on the ventrodorsal view, the gas is highlighting that streakiness. Again, it's probably cloth, but most importantly, this confirms that the material is in the large intestine, not the small intestine, and thus it's of lesser significance most likely. Other things that project into the lumen are intussusceptions. And so remember, these are kind of infoldings of one segment of an intestine into another segment of intestine. And we can see these in the small intestine, but we also see them in the colon. And there are different spots where one might see it in the colon. So colocolic is one part of colon invaginating into another part. Ileocolic is at the ileocolic junction where the ileum invaginates into the colon. And kind of as a subset, you can have of these intussusceptions, cecal inversion, where the tip of the cecum actually invaginates into itself. Usually those dogs aren't quite as sick. The most common of these is the ileocolic intussusception, especially in puppies. And in an older patient, it's often we see these secondary to some other cause of obstruction, and most frequently that's neoplasia, where the intestines are pushing against that obstruction, and that hypermotility actually causes that intussusception to secondarily occur. So in this cat, we're going to start with survey radiographs, and I think one thing that jumps out pretty readily is that there's this big tube of soft tissue in the mid-abdomen, kind of in the plane of the colon. There's rectum, there's colon, and then there's this big tube that's way too big to be a normal colon, but it's in the right spot. There's a little variation in size of the small intestine, maybe a little bit of mild dilation. There is some moderate distension of the stomach, but this area back here is really the most interesting, I would say. As we go to the VD view, it's a little bit tougher to sort out who it is. Again, we have this soft tissue opacity mass or tube back here. Based on the lateral view, I'm convinced it's probably associated with the colon. That would be a harder call, though, on this view. So what we want to know here is this small intestine? Is it large intestine? Are there two populations of small intestine? And presuming this is a descending colon, why is it so big? Again, contrast procedures are your friends, so we did a pneumocolonogram to try to highlight what was going on. We got very nice distension of the descending colon with gas all the way up to this very homogeneous, almost triangular to ovoid soft tissue opacity structure that it looks like the gas is trying to get around. So there's definitely an abnormal something, a mass of some variety there in the colon, and the gas tries to get around it, but it's not doing a very good job. So that would be most consistent with something intraluminal like a foreign object or an intussusception. It's possible this is some pedunculated mass, but the way it looks here is less likely. Let's go to the VD view. Similar structure, similar story, maybe even more compelling that it's a kind of weird shape for a mass the way it projects so far. And even a little bit weird for a foreign object because we have gas trying to get around it for a ways, but then it all of a sudden can't. Most of the time, if there's a foreign object in here causing obstruction or even just passing, if the gas can get most of the way around it, it's going to finish the job and get the rest of the way around it. So it'd be odd to get that far around and then not at all. This really seems like something that is associated with the colon itself, the wall of the colon, and actually projects inward and into the lumen. And so anything that projects that far into the lumen, kind of along the plane of the track, the path of the colon, really pretty much has to be an intussusception at that point. And to go along with that, I can't identify the ascending colon, so if you kind of flip one to the other, it's very believable that this bit of soft tissue, if it flipped back over into the yellow area, would be just about right for the ascending colon. And so this is an intussusception where the ascending colon has invaginated into the transverse colon. It certainly explains why this patient is sick. There is that mild small intestinal obstruction small intestinal distension because there is an obstruction here. It's just relatively distal, and so there's not a great large amount of small intestinal distension. And it turned out that this intussusception, as an older animal, was due to neoplasia, neoplastic infiltrates. So that finishes it up with the colon talks. What did we learn about the colon? Large intestinal diseases, very similar to those in the small intestine, so a lot of overlap in the differentials. As I just said a few minutes ago, other procedures, other tests are your friends, so don't forget repeat studies, don't forget contrast studies, because they can be very useful. And if you're not very mature, you think poop is pretty funny like I do.